of the guideline boards on what's new on the ESO guidelines, both in terms of teams and the processes. Thank you, Terry, for your work.
Thank you very much, Diana. So I've been given a short slot just to update you on some of the work that we've been doing in the Guideline Committee in the last 12 months. So my title is What's New in ESO Guidelines? And I thought I would go off script and just talk a little bit about what's old in ESO Guidelines, which is me. I am now, as of yesterday, the former chair, having worked with ESO Guidelines for a long time. My hair was much less grey when I started in Guidelines. So I am giving this really as a bit of a farewell. And because of my advancing age and my cognitive decline, I'm going to do something now, because I'll probably forget to do it at the end, and that is to thank Diana, to thank Yvonne, if she's in the room, and to thank all the members of the Guideline Board who've made my time chairing the Guideline Board fun. Hard work, but a lot of fun. So, from the old to the new. It's always good practice to start with disclosures, conflicts of interest. I am promiscuous in my guideline work. I do work for a number of national and international guidelines, including SIGN in Scotland, NICE in the UK, and I've done work with European and American guidelines. In guidelines, we always obsess with quality and with bias. And I think I can say, with some certainty, ESO guidelines are high quality. I've worked with all of these other groups, and ESO guidelines are on a par or better in terms of the robust methodology. But I am biased because I'm the chair, so you have to just take that statement with that caveat. So what's new? I want to, over the next 10 minutes, tell you about the new people, the new methods, some of our new guideline titles, some of the new collaborative activity that we're doing in the Guideline Board, and some new products as well. So if we start with people, here are our new chair and our co-chair, Georgios and Diana. The guidelines are in very safe hands with both of them. And here are our newly elected Guideline Board members, official as of our Guideline Board meeting yesterday. And you can see we have representation there from across Europe. We have people at different stages of their career. We have people coming from different backgrounds, and that's exactly the kind of diversity that we want. But what links them all is their enthusiasm for guidelines and for making practice better. If we have new people, that means there are people leaving. So it's a sad farewell to all of the people on the slide here. I've only got 10 minutes, so I won't name them all individually, but I do thank them all for their input. And we do have some continuity. So here's our continuity team, people who were in the board last year that are continuing with us. And I'm looking forward to what all of them are going to achieve over the next year and going forward. So how about new methods? The problems that we face in stroke, the clinical questions that we have in stroke are becoming more and more complex. And to be honest, a guideline that's based on does drug A work better than placebo is no longer the kind of question that we're asking in clinical practice. So as clinical practice has become more complex, guidelines have necessarily had to become more sophisticated in their methods. So to allow us to do that, we have expanded our staff. And we now have an in-house team of methodologists. We have our senior methodologist in RG, very experienced, coming from the Cochrane stable. And then we have more junior methodologists, but junior is perhaps not a fair assessment because actually they are very experienced. We have Anna, we have Leo, and we have Sophia. And with their help, we've been able to really expand some of the methodological approaches that we take to our guidelines. And if I just give you some examples, we have started looking at guidelines that include diagnostic test accuracy. So looking at meta-analyses that include sensitivity, specificity, and the interactions between them. We know nowadays that the question is not often, is a drug better than placebo, but which of a range of drugs is better. So in our guidelines, we've started using network meta-analysis to allow for those comparisons, both direct and indirect. The question often asked by patients is, will I get better? Which is really the field of prognosis research. And we've begun to include prognostic methods into our guidelines. These are all things that have happened already, but there are some things on the horizon. We are working with the Alive Forum to look at the concept of living systematic reviews. That's where the review is updated as soon as new evidence becomes available. We know that there are practice-changing trials being presented right here at the conference. And so we have set up non-disclosures with a lot of those trialists so that our guideline producers can see the data before they're published. And they can start to incorporate those data into their guideline product. And I think what we're going to see over the next few years is much greater use of AI in systematic reviewing guidelines, maybe taking some of the more boring tasks away, but still always using human intelligence to make sense of the data. So what are our guidelines? What are our new guidelines? Well, this year we have published 2 guidelines, one on vasculitis, one on small vessel disease, but we have lots more. In fact, we've got so many new guidelines we couldn't fit them all into this session. So in this session you're going to hear about basilar artery thrombosis, you're going to hear about patent foramen ovale, you're going to hear about intracerebral hemorrhage, but at the same time, in a parallel session, the guideline on aphasia is also being presented. As well as de novo guidelines, we have also created standardised operating procedures around our updates. The problem with a guideline is you spend lots of time synthesising the evidence, you make a lovely guideline, and then a new trial comes along and changes everything. So we now have a procedure for how we update our evidence in a systematic and a comprehensive way. And we have lots of guidelines on the horizon. So perhaps at the conference next year, or perhaps before, you will hear guidance on subarachnoid hemorrhage, post-stroke pneumonia, primary stroke prevention, PRES and RCVS, and a suite of guidelines all on the rehabilitation theme. And also, now that we have a standard operating procedure around updates, we're updating our guidance on carotid artery stenosis, on blood pressure, and there will be new guidelines that encapsulate lots of previous guidelines into one product around reperfusion and pre-hospital management. So that's all on the horizon. If there are topics there where you feel we need a guideline, let us know. So on the ESO guideline website, there's a very simple form. I've done a screen grab there for you to suggest a topic for a guideline. And the board will look at those, and that's how we select a lot of our topics. They come from you, the European stroke community. As well as our own guidelines, we collaborate with other societies, and we collaborate in different ways. So we work on a number of joint guidelines with other societies. We've done a lot of work with European Academy of Neurology. We also act as contributor to guidelines. When guidelines are in a topic area where stroke is a stakeholder, they come to us, they come to the ESO Guideline Board to ask for a contribution. An example of that was a recent guideline by the European Haematology Association. Guidelines from other professional societies come to us for endorsement, for us to make sure that the guidance aligns with what we feel is best practice in stroke. We've recently had a raft of guidelines from European Society of Cardiology to endorse. And we've made other resources as well. If you are part of a professional society or part of a national group looking to produce a guideline, we realise that that's a lot of work. And there's a real risk of duplication, because there's no point in you looking for evidence that we've already looked at as part of our guideline. So we now have a standardised operating procedure that allows us to share all of our resources with other bodies and with other national groups that want to produce their own guideline. And we also want to get the highest visibility possible for our guidelines, so we've created standardised operating procedures for translation of guidelines into local languages. So the last thing I want to talk about are the things that we do other than guidelines. And I want to talk about white papers. So under the auspices of ESO, we have had a number of publications that have called themselves white papers. And they've been a mix of things, from really narrative reviews to really a guideline by another name. What we recognised and what we heard from people was there was a place for guidance on topics that are too new for there to be randomised controlled trials, or maybe topics where there's unlikely to ever be a definitive randomised controlled trial, but the community still want guidance. And so we created another SOP. We've been making a lot of SOPs. We created another standardised operating procedure around guidance that will be completely based on expert consensus, and we're calling those white papers. And we've worked out a method for how we choose the topics, for how we synthesise things, and for how we describe the consensus. So I expect and hope that this time next year, as well as talking about our evidence-based guidelines, we'll also be presenting expert consensus statements. So those are all the things that are new. I want to just end by saying what's not new, what has not changed, and what I know won't change under the leadership of Georgios Indiana, and that is our emphasis on diversity, our robust and consistent approach to methods, the fact that we have so much internal and external quality control. Anyone that's been an author on one of our guidelines will know you are bombarded with peer review and comments just to make sure we're producing something of the highest quality. We also will not change the fact that we want to make our guidelines available to all the people that need them, and we'll continue our work with other societies, we'll continue our work around translation to really enhance the visibility. And the most important thing that won't change is the thing that drives all of the guideline work, which is that spirit of collaboration and the desire to improve stroke care. So with that, I'm going to shut up because you don't want to hear me, you actually want to hear about some guidelines. So I will hand over to Diana to introduce our first